All right. So hello, everyone. Welcome to another Monday subspecialty virtual morning report. My name is Madalena, but you can call me Maddie, and I'll be facilitating the discussion today. So I'm really excited for today's session because we have two really phenomenal educators here to dissect a case with us. So I'm gonna dive into their introductions. So first we have Dr. Lisa Winston. And Lisa, she's a professor in the Department of Medicine and chief of staff and hospital epidemiologist at UCSF at Zuckerberg San Francisco General. So Dr. Winston, Lisa, we're really so happy that you've taken the time to be here with us and learn from you. And I would love if you could, I'm just curious how you got interested in hospital epidemiology and infection control. So if you could just share a little bit about how you got into that space, and then also just something outside of medicine. I think we'd love to get to know you better.
Sure. So I got interested in hospital epidemiology and infection control when I was a fellow. And, it so of course the most exciting thing was getting to see the patients and learn all this great medicine, but then we would also see cases of people who got infections in the hospital, and I realized there was kind of this whole science of things that kind of aligned with antimicrobial stewardship that I really hadn't been exposed to very much before, kind of in my patient care role. And so that was, that was really fun to discover both that it's a really interesting area and that hospitals need someone to do infection control. So that was that's kind of a win-win. And so share something about me outside of medicine. I will just say, I have a great family. So I met my husband during residency, and he is a hospitalist here in San Francisco. And we have twin daughters who are in college. And they are super fun people. And I'm super excited that we'll see them over Thanksgiving.
That's wonderful. Well, thank you again for being here and just for taking the time. So another case discussant who we have, who I don't think needs an introduction in this space, is Dr. Dan Minter. And Dan, he's an ID fellow at UCSF. And Dan, also thank you so much for taking the time, and would love to also hear, share something about yourself that you've been interested in outside of medicine.
Thanks so much, Maddie, and thanks for inviting me here. I just want to start off by saying I'm so incredibly honored and starstruck to be able to discuss this case with Lisa, who, for the folks who don't know her, is the coolest and most brilliant ID person around, and she gets up on a stage and discusses cases in front of thousands of people. So I think she's the bee's knees. I'm just really excited to discuss with her. Outside of medicine, I feel like I had a lot of hobbies before, and they've kind of fell by the wayside. Jack Penner from CP Solvers, he just bought me a fishing pole, so I've been trying to learn how to fish. I tried over the weekend and didn't catch anything, but it was nice being outside. So maybe I'll leave it there. More to come.
That sounds like a fun hobby. Wonderful. And then we have Marcella, who will be presenting the case. Marcella, would you like to introduce yourself and also share kind of any hobby you have recently?
Sure, thank you, Maddie. My name is Marcela. I am a doctor from Brazil, graduated last year. I'm currently applying for internal medicine residency, and I hope to do an ID fellowship. And what I like to do, I think right now I'm enjoying so much to play board games with my family, so trivia games, games like that, yeah.
Awesome. And thank you so much for presenting the case today, Marcella. And we have Shema, who will be doing teaching points. Shema, can you introduce yourself as well?
Thank you, Maddie. Hi, I'm currently a 50 medical student in Berlin in Germany. And outside of medicine, I really like to watch true crime stories and also thrillers. I don't know whether you watch The Watcher on Netflix. I can just recommend it. Yeah.
Fantastic. And then last but not least, we have Promise, who will be scribing today. Promise, do you want to introduce yourself as well?
Hi everyone, my name is Promise. I'm a third year medical student rotating in medicine right now. Outside of medicine, I actually recently got into playing Tetris. Yeah.
I love Tetris. That's so fun. All right. So we are going to dive into the case now. So Promise, you can go ahead and share your screen with the whiteboard. And Marcella, you can feel free to start the case.
Yeah, sure. Let's go. So we have a 21-year-old male. His chief complaint is 3 weeks of fever. So this patient, he reports that 1 month ago, he started feeling hyperexia and malaise. Then 3 weeks ago, he started having some fever, mainly during the night, some chills, nausea, and a few episodes of vomiting. He was diagnosed with unspecific gastroenteritis. He was treated with some symptomatics and went home. But 2 weeks ago, he had a few episodes of loose stools and some abdominal pain. He also noticed the presence of some adenomegalies in the cervical region and the worsening of his fever. It was more frequent than before. So he presented to the emergency department today because he continues to have some nausea, vomiting, and abdominal pain. And also he developed some dyspnea and dry cough in the past 3 days. So that's the first aliquot.
All right. So that's a lot of information, but Lisa, what's going through your mind when you got this first aliquot?
Absolutely. Should I go first, or would you like Dan to take this one first? It sounds like you want me to go first this time, and then we'll switch it up next time.
That sounds great, if that's all right with you.
Totally fine. Totally fine. So, so a lot of things are going through my mind. We have a lot of great information, but of course, there's a lot of information that we don't have. And I'll just highlight a few things that we don't have that, are always great to know about, when you're trying to kind of think about what might be going on. So we know this is a 21-year-old man, and we know the time course of his illness. But we're not sure where he is, which, is always helpful when we're thinking about different infections. If it's an infection that is widespread, or an infection that, or a diagnosis that may be more likely in a particular area. And most of those are going to be infections. I am wondering if this patient is in Brazil, but we will find out more. And then, of course, this is a very young person, so I'm wondering a little bit if they have any past medical history that might help us out, and also, of course, whether there are any exposures, anything interesting in the social history about activities that have been going on, interesting foods that someone might be eating, whether or not there are any animal exposures, whether or not there are any sick contacts to help inform us. And then, there's a few things that, kind of come to mind when we're thinking about things that are, going on for 3 weeks. So I think some things that, we probably won't be thinking about if somebody is, otherwise healthy is, once you're getting to 3 weeks or a month of symptoms, we're probably not going to be talking about things like, is this influenza? We've seen lots of long cases, COVID that takes a while to get better, but usually not in healthy 21-year-old people. So, I'm thinking less about things that are, usually short and self-limited. Some of the other things that can be more serious, I'm also going to think are going to be less likely, because people, usually would have recovered things like, dengue, depending on exposures. Zika, if it's circulating, kind of also fits in there. So things that you usually, if you get, then you get over relatively quickly. But, kind of a variety of things otherwise, and they really fall into, all the buckets of infections, bacterial, mycobacterial, fungal, some of the viruses that tend to last a longer period of time. For example, EBV, I think, I saw it come up in the chat. Always think about typhoid in patients who have abdominal pain. Probably more common that it initially presents with constipation rather than loose stools, but you can get some loose stools later. And then, is this just the beginning of kind of a more chronic illness? We always think about things like, TB, depending on where the person is, we're going to be thinking about endemic mycoses. I'll be excited to hear about exposures to inform things like, Bartonella, Brucella, Coxiella. We can throw out, all our exciting things. And then, of course, we should not forget about our non-ID causes of fever. I'm going to guess that, maybe we're getting presented an ID case since Dan and I are discussing it today. But, of course, patients, when they come in, don't know who is going to be discussing their illness. So they're allowed to have non-ID things as well. Okay, Dan.
That was amazing, Lisa. I can't really add anything. I'm really excited to see where this case is going to go.
Awesome. Back to you, Marcella. Oh, Marcella, I think you're still on mute, but you can jump into the next aliquot. Oh, I think she may have, I wonder if she's kind of trying to reconnect, but while she's reconnecting, I think, Lisa, one of the things that you described is kind of how you really use the time course to kind of filter through your differential. And I'm wondering if you could talk a little bit more, like within kind of the subacute process, how would you make a little bit more progress on that?
Yeah, well, of course, when you're seeing a patient, for the first point in time, you don't know how the illness is going to progress. You only know how it's progressed up to the time point that you have seen them. But there are lots of things that cause you to have a fever and to feel bad that you wouldn't expect to still be going on at 3 weeks. So super common causes of gastroenteritis, for example. So, actually norovirus can have a fever and certainly can have vomiting, diarrhea. So, I'd be thinking about that in somebody who's coming in with a few days, but probably not 3 weeks if they're already healthy. And then some things that, we think of as being more significant, but in healthy people are also usually self-limited, Salmonella, Shigella, Campylobacter, those sorts of GI illnesses. Usually by the time, you're out at 3 weeks or a month, there are exceptions, but, most of the time, for the non-typhoidal Salmonellas, Campylobacter, Shigella, those sorts of organisms, they'd probably be cleared. So that's, kind of where I would be thinking. I don't know yet if this is this is kind of the subacute time course where the patient is presenting. Of course, things that are subacute can go on to become chronic, but we're probably not talking about things that, tend to self-resolve.
Fantastic. Thank you for that teaching. And I see Marcella has been able to join back in. So Marcella, you can dive into the next aliquot.
Thank you so much, Maddie. I'm so sorry. My internet is a bit unstable. So in the past medical history, he didn't report any chronic disease and illness. Medication, he only had some herbal tea and homemade recipes when he started feeling malaise 1 month ago. He didn't know which one. He's sexually active and doesn't use protection. He's a social drinker, denies smoking or drug use. He's a farmer and lives in a farm. So he reports frequent contact with cows, horses, chickens, cats, dogs, sheep. He lives in Brazil, in Minas Gerais. It's kind of in the middle of Brazil, but he had already traveled to kind of almost all regions of Brazil. He reports drinking unpasteurized milk and raw meat sometimes. His father has Chagas disease and his mother has diabetes. And his uncle had tuberculosis years ago.
Well, Marcella, thanks so much for all that really rich history. I feel like this is where like ID folks get super duper jazzed and excited and increasingly paranoid, as has been the case for myself over recent years. So, I love how Lisa kind of put out, this very broad differential of like an undifferentiated febrile illness, maybe with some signal in the gut, maybe with some signal with the adenopathy. And now it's kind of our job to filter through these various sort of exposures to see if we can then alter our differential diagnosis based on what this person may have been exposed to. So I'll say just kind of straight off, as we're approaching this case, this is somebody that doesn't seem to have a noted past medical history. That in itself does not preclude things that could dramatically shift how we think about this case, like HIV. So I'd still think that HIV testing is going to be on my first line of labs that I'm going to send, because if they have untreated HIV or advanced HIV disease, then that could certainly open up a variety of different pathologies that may not be common in folks with a normal immune system. When I look through the exposure history that's listed here, this is somebody who's living in, I don't really know the geography of Brazil terribly well, but Minas Gerais in a farm, I'm going to sort of interpret that in my mind as perhaps more rural Brazil, which is going to raise the risk of sort of like in local endemic fungal infections like Paracoccidioidomycosis, histoplasmosis, cocci, stuff like that, as well as zoonotic diseases that you might see in exposure to some of these animals. A couple of the things that stand out to me in terms of like farm-related exposures, apart from just proximity to cows, horses, chickens, cats, dogs, sheep, stuff like that, is this raw milk exposure. And the sort of short list I have for things that can be transmitted by raw milk are going to be Mycobacterium bovis, so like cow tuberculosis, that tends to present as extrapulmonary disease. It can present with pulmonary disease, but overwhelmingly it tends to present as like an adenopathy or GI disease, because again, you're ingesting it and then it kind of goes out from the GI system. As opposed to going in through your respiratory system. So M. bovis is one. Coxiella burnettii, the agent of Q fever, is something that certainly can be transmitted by proximity to these animals or by ingestion of raw milk. And then brucellosis is kind of the other big one that you can get from raw milk that could then cause like a relatively undifferentiated febrile illness. It often will present, and maybe I'm going to punt this one to Lisa when she comes back on, but I think often can present with like osteoarticular manifestations, but is relatively protean in its manifestations overall. Other things that I think are more common, again, if we like think about what's an endemic disease in Brazil that could be related to this sort of exposure history, I think is visceral leishmaniasis. It's something that's not really present in other parts of Latin America. You get like cutaneous or mucocutaneous leishmaniasis in Peru and other parts of Latin America. In Central America as well, but in Brazil itself, I'm not sure in Minas Gerais necessarily, but in Peru itself, you have the visceral form, which can cause kind of a fever of unknown origin with like hepatosplenomegaly and bone marrow failure. And that can certainly be something that you see in conjunction with dogs, since dogs, I believe, are intermediate hosts for that. Other things like the cats can bring up Bartonellosis. Chickens, I think the most common association I have is with non-typhoidal salmonellosis. If this person's walking around barefoot, then you bring up the idea of sort of geohelminths or parasitic infections that come in through the dirt, or that will puncture your skin if you walk barefoot, and then can cause a number of illnesses. I think that's kind of where I'm at so far. If I were to take a step back in terms of common things being common, this is like approaching fever of unknown origin territory in an area of the world that could be endemic with tuberculosis. So I'd say tuberculosis testing would be of the utmost importance. Viral infections are probably going to be, less likely, like Lisa said, unless it's something like, an infectious mononucleosis syndrome or something that's related to HIV. And then, typical bacterial infections, I think, are going to be pretty unlikely at the 3-week mark, although atypical stuff, like I mentioned with Brucella, Coxiella, Bartonella, could cause sort of a longer course like that. And then, if we move on to parasitic infections, like I said, the geohomins like strongyloidiasis could feasibly, I'm not sure if that caused so much of a fever if it was just like a run-of-the-mill strongyloides, but be something to consider. This is probably a part of the world that has endemic malaria, although I'm not sure about that, but definitely fevers in a returning traveler. I consider malaria, and I think that there's falciparum malaria in Brazil in addition to Vivax. And then for fungal infections, I kind of say if this person is immunocompetent, I think amongst people with normal immune systems, the endemic fungi, so like histo, blasto, cocci, and paracocci, can cause disease in people with normal-ish immune systems versus like some of the other fungal infections we may think of as more common in people who are dramatically immunocompromised. I think going forward, I'd like to see if there's any signal on our exam or our labs or our imaging that I could then say, oh gosh, this is, fever of unknown origin with this really cool exposure history and, a pulmonary nodule or something like that, or something in their belly or something that could then use as a fulcrum. But I say there's a very rich exposure history here that I'm excited to see where this case evolves. Lisa, what do you think? Anything you would add to that? I feel like this person is every exposure in the book.
Yes, I'm kind of really enjoying this case. I sort of feel like, for an ID person to get to hear about a case in a young person who doesn't have any mass medical history, who has kind of every exposure that you'd want to think about. I feel like in some ways, Dan and I are just like throwing out every possible infection. And so I think the trick is going to be narrowing it as we get closer. But some of our standard tests, I think, will really help us. There's probably just a couple of things that have it. There's probably more. There's always more, right? But there may be a few things to mention we haven't talked about so far. With unpasteurized milk, I always think about listeria, but not quite the right host for listeria, probably not quite the right timeline with an extended febrile illness. But, could that be the GI and adenopathy? Maybe. I think Dan's thought about Brucella, which can definitely present as an undifferentiated febrile illness, and somebody who has exposures is right on. A couple other things I'd throw in there, liver abscess with abdominal pain, 3 weeks of fever. You can get some irritation of the diaphragm. Is that why he's coughing? Leptospirosis. This has been going on for a little while. You might have thought he'd either be worse or better by this point, but get pulmonary disease sometimes with lepto, if you've inhaled it. So that's kind of on your list. I don't want to forget yellow fever, which has had, a bit of a resurgence. We're not hearing anything that, is specifically making us concerned for that so far, in terms of the complaints. So we've got a lot of stuff here, and we haven't even discussed non-infectious things. So, but maybe we'll wait to see what we get in our first pass of labs before going there.
All right, such a rich discussion and dissection of all the details of that social history. So Marcella, why don't you give us the physical exam?
Sure. Oh, I'm loving this discussion. That's amazing. Thank you. So the vitals, the heart rate was 102. respiratory rate 23, blood pressure 104/52, O2 saturation 92% on room air. So the patient was awake, alert, and oriented ×3. He was kind of ill appearing, very thin. We were able to find some cervical lymphadenopathy. He was a bit dehydrated, also had some inguinal lymphadenopathy. On the chest exam, he had some crackles on both his lung bases. Cardiac exam was normal. And his abdomen exam, he had some hepatosplenomegaly with some mild pain on palpation. And he had a bit of low extremity edema. He was not febrile on the exam. Yeah. Would you like me to stop here or some basic labs first?
Whatever our moderator prefers.
Yeah, well, I would, if it's all right, maybe we could stop here. Lisa, I would love to just hear your initial thoughts on this physical exam and kind of what's jumping out to you. Yeah, I'm just very interested to hear your take.
Yeah, well, so a couple of things, and I think we're still in the realm where things are a little non-specific, but I'm going to point out a few things that I want to, try to explain and get my head around a little bit. So the first thing is that the patient is ill appearing, I think, and I think we also heard very thin, which does make me wonder a bit about chronic underlying illness. So Dan mentioned HIV, also wondering about things like tuberculosis, but wondering, is it possible that this has been going on for more than 3 weeks, more than a month? Is there something that has potentially been going on a bit longer that might be informing us? The fact that he is ill makes me, think a lot about what setting we're going to try to, work this patient up and how quickly we're going to do that. So, this would be a patient that I think we'd like to do an expedited workup on as we can, because, he's not robust and healthy appearing. He is ill. And then the other thing that I will say, we were kind of expecting the adenopathy. The hepatosplenomegaly, maybe not a huge surprise in somebody who we're thinking about adenopathy, reported fevers. I think we're kind of thinking reticuloendothelial system. The liver and spleen are part of that. So I'm not super surprised about that. But this patient has hypoxemia and an abnormal chest exam also. So I think whatever we are going to bring in as our potential diagnosis here, we're going to need to explain those findings also. And then, of course, the other thing that comes up in somebody who may not be well at baseline, a 20-year-old healthy person, I'm going to think a lot about a single unifying diagnosis. But if somebody has a chronic illness underlying, could this be an exacerbation of a chronic illness? Could there be something, on top of that? Certainly our patients with HIV are rather famous for having more than one diagnosis that, can explain what's going on. So I think we do want to keep in the back of our heads, just the possibility that we might be dealing with, more than one thing that's explaining this patient's illness rather than tying it all together. And then I'm not following the chat perfectly, but I think I have seen coming up a few times, could there be an infection that's leading, to cardiomyopathy, and then the patient is volume overloaded? Absolutely. I think those are things that we should be thinking about. And, with the lower extremity edema, wondering about that as well. Although I don't think we're getting other and we have some crackles in the lungs, but I don't think we're hearing about, elevated jugular venous pressure, for example.
All right, fantastic. And one question I just had is, with the hepatosplenomegaly, the hypoxemia, and abnormal chest exam, like how would you approach a workup in this case?
Dan, do you want? I think Dan is extremely well poised to answer that question as somebody who's doing this every day. Would it be okay if Dan takes that?
Yes, definitely.
Sure. I think like Lisa was kind of hinting at, it's still pretty non-specific right now. So I think if we can find anything that we can really hang our hat on and say, gosh, this is fever plus whatever, then that will kind of serve as our pivot point in this case. So certainly bringing this patient into the hospital, getting basic labs, getting basic culture data, and then I think for this patient, probably imaging is going to be pretty important. So does this patient have like a cavitary lung lesion and then is just systemically ill and has hypoalbuminemia and volume overload and stuff like that? I think that would dramatically change this case going forward. And then similarly, I probably at this point, if I was in a setting that had the resources, and there was any suggestion of abdominal pathology on exam like this hepatosplenomegaly, I'd probably plan for a CT scan, which could show us a lot of stuff. And hypothetically, maybe it shows us hepatosplenomegaly and necrotic nodes all throughout the abdomen. That could kind of refocus our differential diagnosis and then provide us with something that we could go after as a diagnostic test in the form of a biopsy. So, I think at this point, beyond basic labs, beyond basic imaging, I'd probably, start thinking about what advanced imaging I'd want to get for this patient in terms of maybe identifying some sort of tissue thing that we could sample.
All right, thank you. Okay, Marcella, give us more information.
Sure. So some basic labs first. We have a hemoglobin 8.9, hematocrit 27.5, platelets 118,000, leukocyte 4970, with 6% bands, 54% neutrophils, 14% eosinophils, 20% lymphocytes, and 6% monocytes. The BUN was 15.08, creatinine 1.03, sodium 131, potassium 5.8, calcium 11.7, albumin 2.5, AST 125, ALT 179, GGT 139, alkaline phosphatase 89, bilirubin total 1.6, direct 0.7, and indirect 0.9. His ferritin was 1430. And the chest X-ray had some ground glass opacities in the lung bases.
So Marcel, did you say he had an eosinophilia as well, or did I miss that?
Yeah, it was 14%.
Well, maybe I'll start tackling this, Lisa, and then toss it over to you. I think I'm going to maybe approach this with what did I expect to see and what am I surprised by? So with hepatosplenomegaly and adenopathy, like Lisa said, that kind of maps to the reticuloendothelial system, or kind of the highway where macrophages and other mononuclear cells go. Part of that is also the bone marrow. So that's a pattern that I'll often sort of map in my head is like, oh, hepatosplenomegaly plus bone marrow disease can kind of come together. So that, the fact that he's got bicytopenia, so low hemoglobin and vaguely low platelets, isn't terribly surprising. The things that do jump out is like, oh, wow, I wasn't really expecting that necessarily, are the hypercalcemia. So uncorrected calcium of 11.7 in the context of low albumin. So it's going to even be, I can't do math on the fly, but it's going to be higher than that when you correct it. I think that is something that's a little bit interesting, and we can think of like a differential diagnosis for that. So maybe I'll circle back to the hypercalcemia. And then also the liver function test. I guess maybe not terribly unexpected in the context of hepatosplenomegaly, but this low-level transaminitis suggests that it's not, just big liver, but it's also a liver that's having some sort of cell turnover. And then lastly, the ferritin being 1430, it's, that's, definitely elevated beyond what we tend to expect. Although in the sort of situation of like a febrile illness, you can definitely see that. So maybe if, again, we kind of work on like piecing things together, one thing that comes up a lot in our like morning reports or case discussions is the idea of secondary HLH or hemophagocytic lymphohistiocytosis. And, in adults, while in pediatric patients, this is certainly something that can be primary and, the result of a genetic defect. In adults, it tends to be driven by something, whether that something is a cancer, an infection, or an autoimmune disease, remains to be seen. In this case, in the context of infections that can drive this, tuberculosis has certainly been known to do it. Visceral leishmaniasis, histoplasmosis, I think are some of the more common ones. And then in terms of viral things, a number of disease, viral diseases like herpes viruses, like EBV can drive it. And then also it can be part of like the syndrome of like multicentric Castleman's disease driven by another herpes virus, Kaposi sarcoma associated herpes virus, or HHV8. I think you could also just have like a whole, any number of infections can drive this, and it's more of an immune dysregulation than anything. Why am I saying HLH? In part because it's, a criteria, it's like a syndrome where you piece together different parts of the criteria. And just off the top of my head, some of the things that would fit would be the cytopenias, the hepatosplenomegaly, the fever, and the hyperferritinemia. If we had a hypertriglyceridemia, that would be another criterion. And then some of the more advanced ones like NK cell activity or IL-2 receptor activity, those would be, other laboratory criteria. And then as a pathologic criterion is if you got a bone marrow biopsy or liver biopsy and showed hemophagocytosis or a macrophage, like, Pac-Man eating a red cell. So that's all to say that, he has some inflammatory syndrome that I'm anticipating is going to be driven by an infection in his case. So what other progress can we make on this? Maybe I'll just circle back at this point to two things, the eosinophilia and then the hypercalcemia. Eosinophilia, it gets everybody super excited. I will say it's my favorite white blood cell, because it brings up a whole bunch of differential diagnoses, many of which are infectious disease related. From the infectious disease standpoint, it tends to be tissue invasive helminths. So, not necessarily like Giardia or some luminal parasite. It's when the parasites leave the lumen of your intestine and migrate to the tissues that really, really kind of pisses off the eosinophils, and then you get really high levels in the blood. It can also occur in some of our endemic fungal infections like coccidioidomycosis. In folks who have invasive aspergillosis, you can also get eosinophilia. I don't know so much with paracocci, but I kind of think of it as like cocci adjacent or blasto adjacent. And I imagine you could probably get eosinophilia there. I will say some caution in a tropical setting for eosinophilia, because this person may have, low level, some exposure to helminthic parasites or filarial parasites that gives them an eosinophilia any day of the week, and may or may not be related to his current presentation. So I'm going to put like a asterisk around that, and it may be something that's super, pivotal to the case, but it also may just kind of be a red herring in his case. The calcium is super high, and then when I think calcium, hypercalcemia, I think is it PTH mediated, so parathyroid hormone mediated or non-PTH mediated. If we were given a FOS, that might be a clue, because PTH kind of drives the FOS down. I know Robbie and Jack say PTH is phosphate trashing hormone, so it drives it down. The other thing that's probably more relevant from an infectious standpoint is vitamin D mediated hypercalcemia in the context of granulomatous disease. So could this be consistent with tuberculosis? Yes, and TB or other granulomatous infections are known contributors to hypercalcemia. So if this patient had an elevated 125 hydroxyvitamin D, that would be supportive of this being driven by granulomatous reaction as opposed to something else. So stepping back, I think that he probably will end up meeting criteria for secondary HLH. Does that dramatically change our differential diagnosis? Probably not. The eosinophilia, I think, is interesting, but may or may not be the clue to this case, because there's other features of this that aren't terribly consistent with the tissue invasive Hillman. But who knows? I'm happy to be wrong on that front. And then lastly, the calcium. I think the calcium is probably going to be the most discriminating factor of this case going forward. And I'm going to have in sort of top of my mind of whether or not that he could have an underlying granulomatous infection that's driving both his fevers and driving this hypercalcemia. Lisa, what do you think? Anything else you would add?
Well, that was fantastic. I will not add very much because I really like your framing, and I agree. I think the calcium is something that really jumps out at you. One of the things that I think helps us with eosinophilia a little bit, although you can get fooled. So the percentage here is definitely high, 14%. But the total white cell count is normal. So the total number of eosinophils, it's high. It's definitely abnormal, but it's less than 1,000. And so, once you start getting to the higher levels of eosinophilia, I start thinking more about eosinophilic processes. And so at this level, I'm definitely thinking about some of the granulomatous diseases that are frequently associated with more modest eosinophilia. And, given the elevated LFTs, and we've kind of got granulomas on our mind now, I think we're maybe thinking, well, gosh, is this, one of the many things that can cause granulomatous hepatitis? And is that causing our relatively, modest eosinophilia? And, a pretty good ferritin elevation, but it's not above 10,000. So we're not like freaking out that like, oh my goodness, the ferritin is super high, and we need something, really clear to explain it, and not just, significant inflammation.
Yeah, I'm just kind of blown away by the teaching here, from hypercalcemia to eosinophilia to secondary HLH, just really phenomenal teaching. So I will just pass the mic back to Marcella so we can get more information.
Thank you, Maddie. So HIV was negative. Also screening for Hep B, Hep C was negative. He had a CT thorax, showed mediastinal lymphadenopathy, small ground glass opacities on both lung bases, and the abdomen CT showed diffuse lymphadenopathy and hepatosplenomegaly, small ascites, and some enlargement and some nodules on his adrenal glands. Also, the team decided to collect morning cortisol that was low. The next will be the final diagnosis.
All right, so maybe we'll pass the mic to you, Lisa, to get your thoughts on this aliquot.
Yeah, absolutely. Well, we don't yet have any culture data that hopefully is starting to come back in. Some of the things that we have talked about, you might be able to pick up on a blood culture, although you can't always. Brucella, as an example, we might pick up. With somebody in whom TB is definitely going to be on our differential, I think we're going to be trying to collect some sputum to try to figure out, if that's what's going on. And then I think depending on what's available to us in our laboratory, we're going to be sending a variety of serologies in addition to the first cultures we're sending off. So we're going to be sending, particularly for fungal serologies, Q fever serologies, those sorts of things to help us narrow things down. But let's just say that, we kind of get to our first pass and, we got a few sets of blood cultures and they're not growing anything, and either our serologies are not available to us or they're negative. How are we going to make the diagnosis here? And so we have some choices that are always good to look at with our imaging colleagues to figure out what looks the most abnormal. But we could think about doing a liver biopsy. We could think about sampling an accessible lymph node, although, we always want to be careful, for example, with with certain lymph nodes, like, for example, inguinal lymph nodes, unless they're really markedly abnormal, can often be reactive and might just not quite give us the answer. So those are the things that I'm thinking about, like, okay, what are my initial tests showing, and then what are going to be my next steps in terms of nailing down the diagnosis. Maybe Dan can go, and then if you need us to put our nickel down, we'll have to pick something.
Oof. Yeah, no, I agree with all that. I think this is a tissue is the issue sort of scenario. And if we kind of take a step back to the previous aliquot, we're like, okay, the calcium gets us to granulomatous disease. Now we have granulomatous disease. And probably the most striking thing on the CT is the sort of dramatic lymphadenopathy with the hepatosplenomegaly and adrenal gland nodules. So I think that if we map it onto granulomatous disease, my money is probably going to be on a mycobacterial infection at this point. But this sort of presentation could occur with a variety of different diagnoses. So I think in my year and a half of ID fellowship so far, I've been wrong several times. So I'm going to be humble and say this could be a lot of different things. But if I had to guess, I'm thinking probably mycobacterial disease. And yeah, I want to get one of those biopsies at this point. Lisa, what do you think if you had to pick?
Yeah, well, many times when we are asked to decide, you have to put your money down on something, you're struggling between, well, do I want to say TB? Because it could always be TB. And in real life, it's usually TB. But I really do think that we have other things on the differential here, including our endemic fungi. And, I guess one of the things that I would be interested in trying to sort out with talking with the patient is, how rapidly progressive was the disease? And if it was a little more rapidly progressive, maybe I'd be thinking a little bit more about fungal disease, if we could come up with, some particular time of, inhalational exposure and then dissemination, but TB, we think about it as, people being chronically sick for a long time, but but not always. The other thing is we're not coming up with, I don't think, any particular risk factors for why this otherwise healthy 21-year-old happens to be if he's got a disseminated fungal infection, why did he get so unlucky? And he has that, and that can happen, but it makes us wonder. So we should probably pick something. I don't know if we should pick the same thing or something different.
I'll say bovis just because I like the raw milk thing, and this seems like extrapulmonary more than other stuff. Yeah. I don't know if you want to choose something different, Lisa.
Well, I think that is a wonderful guess, and would also be really nice to know, if anyone else were sick. Be great to know a little bit more about his uncle's disease. So I really like that guess. I suppose. Yeah, I like that guess. I suppose I can go with something different. If the patient had different risk factors, I think this would be a really nice story for histo. Depending on location with the elevated ferritin. And of course, histo is found worldwide. You know, but as far as we're getting, you know, not a hot spot. So I don't know. I guess I'll go with endemic mycosis, and so maybe I'll say paracoxy. Although I really like Dan's guess.
We can do a joint guess. So we have like guess A and B. So
this is fantastic. I think it's just both of you walking through your reasoning has been so clear, and just so much learning. So thank you. All right, Marcella, I guess we'll hear the last aliquot.
Sure. Yeah, thank you so much for the discussion. It was amazing. So we did the workup for TB, sent some serologies, and also the blood culture. But often in our hospital, depending on the place here in Brazil, they take a long time to come back, and we have to send to another lab. It's kind of one of the limitations. So we went for the tissue. And he had a lymph node and an adrenal gland biopsy that showed granulomas with central necrosis. And in addition, some yeast elements with multipolar budding with variable size, indicating the presence of Paracoccidioides brasiliensis. So he was diagnosed with acute juvenile form of paracoccidioidomycosis.
what a case. You know, it's something we see on a daily basis here in San Francisco. So I'm glad that you said it.
Yeah, amazing, and I will just say, I don't think there was. I think as far as we could get without the tissue was we could get to we are suspicious for granulomatous disease. We might even get to the point where we're treating empirically for an endemic fungal disease, you know, once we have our tissue plus tuberculosis, you know, with the thought about M. bovis. I would not be surprised if, you know, given that he's sick, if we have him on empirical therapy for both those things while we're waiting.
Super fascinating case, though. Yeah, I'd love to learn more about this disease.
Yeah, phenomenal discussion. I think a question for Dan and Lisa is, Lisa, you mentioned paracoxy at the end, and I'm just wondering kind of at what kind of pushed you off to say that, and did the involvement of the adrenal glands, I don't know, I'm not familiar with paracoxy involving the adrenal glands, and if you could just share a little bit about what made your mind kind of go to that organism.
Oh, geography. So, you know, I had to pick an endemic. So Dan took the mycobacteria, which I thought was a brilliant choice. And so, since I'm going with something different, I'm gonna go with an endemic mycosis, and you know, maybe that explains why it was a little faster, as we talked about. And so then when I think about, well, which one is he most likely to be exposed to? Because there's a fair amount of overlap. I think paracoxy was the winner there, but it could have, you know, as I said, you know, if he was presenting, so the patients that we see with histo at our hospital in San Francisco are mostly coming from Central America. So if he'd been coming from Central America, then I would have picked histo.
I think in retrospect too, maybe a clue may have been like the mediastinal adenopathy. You know, again, I've never seen a case of paracoxy, but from my reading, I think most of them are inhalational, and then they kind of go out from there. That's kind of like how a lot of the endemic fungi work, is they come in through your lungs. You know, oftentimes they're stopped by your lungs, and then they don't disseminate further. But in occasional cases, they'll go out into, you know, a more disseminated fashion. I was kind of anchoring on there not being a ton of pulmonary signal, but maybe the mediastinal lymphadenopathy suggested, you know, sort of an initial pulmonary focus.
Yeah, and Marcella, how did the patient do? Any other information you have about the case?
Yeah, he did well on treatment. he was falling on our clinic. We have here in the hospital I graduated, we had a clinic just for like infections in general, and we had a lot of cases like that treating. It's a long treatment. Sometimes we had some patients with the other form, the chronic form. That's also very fascinating. So it was an amazing case to learn more about this disease. And also another hint was that I said that he's a farmer and he used to work with coffee plantations. And some people say that it was like association working with coffee plantation and getting this disease through inhalation. Yeah.
Marcella, thank you so much for preparing this case and presenting it, so beautifully. And I guess I just wanted to, before we learn some teaching points from Shema, Dan and Lisa, any last reflections on this case?
No, thank you so much for presenting it to us, Marcella. That was a really, really fun case, and I love learning from you guys about the diseases that are more common in Brazil. So thank you so much.
All right. Well, I think we can pass the mic to Shema. So again, Dan and Lisa, thank you so much for your phenomenal teaching and discussion. And again, Marcella, thank you for presenting the case. And Shema, take us away with teaching points.
So first of all, thanks a lot for this great case, Marcella, and Dan and Lisa for this amazing reasoning. So I will start with some quick teaching points. So having fever as a chief complaint, we always go through our IMATE mnemonic that we have. And actually, the more acute the fever is, the more we prioritize actually infection. And I also wrote down a mnemonic that I know from Charlene, who's also here, that's for fever in the returning traveler. It's I love SAF. So as we also learned from Lisa, so incubation, the season, exposure, recent travel, and the host are important. Like, how is the immune status of the host? Is there any underlying immunosuppression? And then we had fever and a subacute time course, and we should then prioritize granulomatous infections like mycobacteria, also zoonotic and endemic mycoses, tick-borne, and also when it comes to viral infections like HIV. And then coming back to the localization, like we learned that the patient is from Brazil, which makes us prioritize in terms of infections endemic mycoses like paracocci, which is also known as a Brazilian TB, also leishmaniosis, dengue, Zika, Chagas. And then when we think of infections and that are transmitted via raw or pasteurized milk, think of Mycobacterium bovis, Listeria, Brucella, which are the main culprits that we should know of. And then if you have hepatosplenomegaly and lymphadenopathy, usually think of an involvement of the reticuloendothelial system. And then we also had this very high ferritin, and we learned by Dan to think of HLH. We can differentiate between primary, which is usually genetic, and also secondary, usually due to lymphoma or infections like TB, leishmaniasis, histo-EBV, and also think of multicentric Castleman disease. And therefore, looking how probable HLH is, there is the so-called H score, like if you have high triglycerides, low fibrinogen, etc. And if you have infections and eosinophilia, we also learn to prioritize a tissue invasive disease, but also think of endemic mycoses. And we also learned that granulomatous diseases can be accompanied by modest eosinophilia. And then for the hypercalcemia, in terms of infections, always prioritize the granulomatous infections, as we learn, because this is where we produce 125 vitamin D. And then the framework for hepatosplenomegaly, hypercalcemia, a subacute time course, prioritize the granulomatous disease. And then together with the with Brazil, it came out to be paracocci. And there was also one thing mentioned in the chat about paracocci being associated with adrenal insufficiency. So yeah, that's all. Thank you so much, Marcelo. And also thank you so much, Dan and Lisa, for this amazing discussion.
All right, and Shema, thank you to you for these incredible teaching points. Amazing how you summarized all of the learning. Well, again, just thank you everyone for tuning in. Lisa, Dan, for taking the time to give your teaching, and we'll see you all at the next VMR.
Thank you. Thanks so much for the invitation. Really appreciate the opportunity.
Thanks so much, everyone.
Well, thank you.
Thank you.
Bye, everyone.